Welcome all. Glad to have you here today. Just a reminder that the meeting is being recorded, and to make sure you're muted and to use the raise hand and Q&A function if you have questions or comments. Before we get started with our guest today, I want to just first provide a little bit of an overview about our Georgia State University Prevention Research Center. So for those of you who aren't aware, Prevention Research Centers are a network of CDC funded academic research facilities in the United States that study how people in their communities can avoid or counter risks for chronic illnesses. And our Prevention Research Center at Georgia State is headquartered on the Clarkston campus at Perimeter College. And we are working with community organizations, state and local government, residents, and other partners in Clarkston to develop, implement, and evaluate culturally and linguistically responsive interventions to address disparities and determinants of health for migrants and refugees, and to disseminate that work at the community, state, and national level. Today, I am very excited to have Dr. Rima Afifi with us from the University of Iowa. She is a professor, director of the Prevention Research Center for Rural Health there in the Department of Community and Behavioral Health. Dr. Afifi engages in public health research and practice with intent to promote social, community, and policy environments conducive to well-being. And whenever possible, she uses methods of community-based participatory research, applies an ecological lens to the understanding of these issues, engages multiple disciplines to widen the perspectives on any topic, and emphasizes knowledge transfer of research to practice and policy. And she's really particularly interested in intervention and implementation science. And most of Rima's research and practice has really centered on adolescent and youth health and well-being, and on the Arab world. And this has infused her research and practice with critical reflections on the impact of global politics, economics, and trade, of war, conflict, and contexts of uncertainty, and as well as the power of youth agency and voice. So I'm pleased to introduce you to Rima, and I'm going to stop sharing now so that she can share her slides. And Rima, feel free to provide any additional introduction to you and your work.
Thank you so much. Thanks. That was a wonderful introduction. And welcome, everybody. It's good to be here. I will share my slides and make sure that I can make it happen. And then I'll start, I will start talking here. So 1 second. All right. Can you all see my slides?
Yep.
All right, wonderful. All right, so good morning, everybody. Actually, it is morning where you are, I think. Good morning, everybody. I'm in Beirut, Lebanon right now, so it's 6 o'clock here. And just happy to be with you and to share some of the work that we're doing with the Syrian refugees in Lebanon around mental health. I will say that I have access to internet 24/7, but every once in a while the electricity will go off, and when that happens, I'll be a black screen for a while. I will continue, the electricity will come right back, so don't worry about it. Just wanted to give you a heads up. I am director of a prevention research center for rural health, similar to GSU's Prevention Research Center. This work that I'm talking about is not under that PRC umbrella, which is why I don't have the PRC logo on here. So this work is actually funded by the National Institutes of Mental Health under this award number, and it's funded for 3 years. It's an R34 from September 1, 2021 to August 30, 2024. So we have about a year left on this research. I'm going to sort of tell a story of the research because I think that's part of what makes our work exciting, rather than sort of this is what we did and this is what happened. And it's more, you know, what are the issues that came up for us while we were doing this work? What were the challenges? What were the beautiful, facilitators and really exciting things that happened along the way? And so I hope that through this, I will show you a little bit of data and sort of give you the background of how we got into it, but hope to be telling a story. All right, so just to start, I think that in all research, we should ask about positionality. And particularly in global health research, I think this is important because if you hear about or read about global health research that is done completely by individuals that don't live in the spaces that are being researched, I think we should always question that and question the politics and the power that leads to that sort of research. So a little bit about my positionality. I am a Palestinian American. My father is Palestinian. My mother's American. They met in Beirut. I was born and raised in Beirut and left here in 1984. So I was here during quite a bit of the Civil War. Was in the United States for 13 years, got all of my education in the United States, BS through PhD, and then moved back to Lebanon and worked at the American University of Beirut for 20 years from 1997 to 2017. And then moved to Iowa, which is where I had done my BS and where my parents had moved in 1984. I'm one of those people that sort of went reverse. There's a lot of people that are from majority countries, which is what I like to call, what others call low and middle income countries. A lot of people from majority countries end up in minority countries doing work for most of their lives and then move back to their countries to care for their, to be around their parents as they age. My parents were in the United States, so I did the reverse. I moved to be closer to my parents as they were aging. I'm so happy to be in Iowa, and I just the last 5 years have been wonderful, or 6 years now. So that's sort of where I come to this work from. I come to this work from a combination of both, trauma and privilege, and real connection to this space where this research is happening. All right, so in terms of background, I should have said, the title, as you saw, is Young Adults as Community Mental Health Workers in Humanitarian Settings, a pilot test of the mechanism of effects on their own well-being. So in this project, we're actually a little bit flipping the narrative. Instead of the emphasis being on the recipients of services, the emphasis is on the implementers of services. And you'll see in a little while, but our hypothesis is that when young adults, particularly under situations that are difficult and stressful and uncertain, when they are able to serve their communities, that gives them a sense of purpose that's really good for their well-being, and it gives them skills that gives them hope for a future. So that's sort of with the end in mind, this is what our project's about. All right, so just to start with young people, there is 1.8 billion young people that are between 10 and 24 in the world today. We know that if young people are engaged effectively, they are incredible resources and agents of positive change in their communities. And that involving youth and young adults in works that impacts their communities has positive outcomes for their own well-being and for their communities. So this is research that we know. But youth and young adults are often really marginalized. So if you look at any crisis situation, if you think about even in the United States, when there's hurricanes or tornadoes or whatever, the pictures that you see on TV, and I hope you start to notice this, is often about older adults, it's about children, it's about adults, but you rarely see adolescents and young adults in any pictures, as if they're not even there. So this group that has so much potential and so much energy and wants to support their communities is often marginalized, and they're particularly marginalized, it seems, in these crises. We work in humanitarian settings, despite the fact that we know that they've been really active interventions agents before, during, and after some of these crises. Now, if we take the premise that youth are really active and can support their communities, we want them to be meaningfully involved and engaged as intervention agents. And so in that case, their work should focus on a community need. So if you think about humanitarian settings, there are many community needs. One of them is related to mental health. So we know that humanitarian crises increase mental health disorders, and that even normal distress, and I'll come to this idea of what is mental health, but normal distress and psychological reactions affect a large percentage of the populations, even when they're not diagnosable mental conditions. And at the same time, we know that human resources for health are insufficient to meet the needs. So we have too few resources to meet the needs of mental health and many other aspects in humanitarian settings. So the whole premise is, if we can understand the capacity of youth to support communities in contexts of disasters, we learn a lot. The community is better, young people are better, and it helps us understand what we need to do going forward. So that's why the focus of our intervention is on engaging young adults meaningfully in work that impacts their community and enhances their well-being, and then on assessing the impact of that engagement. The context of our research is the Syrian refugee crisis, which is now in its 13th year and has resulted in one of the worst humanitarian crises in recent history, with over 6.3 million Syrians fleeing Syria. Lebanon hosts nearly 1 million displaced Syrians, the largest number of refugees per capita. Lebanon is a very interesting and unique country in that it has hosted about 500,000 Palestinian refugees since 1948. It has hosted Iraqi refugees since 2003. It now hosts over 1 million Syrian refugees, all in a country of 3 million, 3.5 million. So about 1 in 4 persons in Lebanon is a refugee. This is also amidst and alongside persons who are Lebanese who are also struggling to survive. So it's a really difficult context, particularly now, and I'll talk about the now context soon. But we know that in Lebanon, about 60% of the refugees that are between 15 and 24 years aren't employed, and they're not in school, and they're not attending any training. So there is opportunities here to work with young people in work that they'd like to do in service to their community. So this pilot study aims to specifically evaluate the feasibility, acceptability, and fidelity of Syrian refugee young adults as community mental health workers and in their own communities, and the impact of the work on their own outcomes of well-being, coping, and stress. And we, in the meantime, we're trying to assess the mechanisms leading to any change in those outcomes. We're working specifically in Syrian refugee catchments in the Bekaa region, the Bekaa Valley of Lebanon. Now, to take a step back, the way that we approach this is from a positive mental health, strength-based or asset-based, dignity-centering, narrative-changing approach. And I hope that you see this as we go through the presentation. So we aren't coming at it from a biomedical model. We're definitely not coming at it from a perception of mental illness as a negative thing. We are not considering that this group of refugees is completely dependent, so it's not a deficiency narrative. And we're really trying to center dignity of people while at the same time changing the narratives around all of this. So as an example, as I said, there's about 1.5 million Syrian refugees in Lebanon. So you can imagine within that group, there are teachers, there are nurses, there are physicians, there are engineers, there are all sorts of people. But all of a sudden, the only label that they seem to be able to hold is the label of refugees. And the humanitarian complex will bring in all sorts of people. The Lebanese government will do that as well, like as if there is nothing, there is no asset in that community, as if the only way that we can approach them is from a refugee perspective. And so that's part of the changing narrative portion of the work that we're doing. So when we think about mental health, we think about the continuum of mental health, this idea that, at any point in our day, in our week, in our month, in our lives, we go up and down on a mental health continuum. And there's probably none of us that are 100% mentally well, nor is there anybody that's 100% mentally ill or not well, that we go up and down. And I mean, if you think about yourself, some days I wake up and I think I'm just really feeling great. I can conquer the world today. And other days I'll get up and I don't know what it is, but I feel like I just can't do anything. And there's a lot going on around us that influences that, a lot that, of our own trauma that we're experiencing that influences that. So this is the continuum that we bring to this work. It is the definition of mental health from the World Health Organization as well, which is a positive mental health definition. This is a figure that I really like. It comes from a Lancet Commission on Global Mental Health. And what you see sort of in this picture, and the reason that I like it, is that you have the continuum from mental well-being to particular specific mental syndromes. And what you see on the left, on the right, is sort of, well, first, the factors that are influencing mental well-being at the top are just, they influence us all. It's the environment that we're in, it's what we're experiencing. And then you funnel down to fewer, it's like a pyramid, right? So fewer people at the top of the pyramid that may need very specific intervention. But at that top, the interventions are very wide, and there's a lot of evidence on low intensity psychosocial support interventions that can happen in communities peer-to-peer. And that's the work that we do. So we do work in communities, in this case, in Syrian refugee communities, to provide psychosocial support with using an evidence-based intervention, which I'll share shortly. So globally, what we know is that there's a lot of evidence on these task-sharing interventions. And task-sharing interventions are interventions that train non-professional lay community members to provide mental health care in low-resource settings, including humanitarian settings. And community mental health workers have been known to implement low-intensity mental health interventions effectively to decrease mental health. I'll take a pause here because when I moved to Iowa, I was really worried that none of my skills would be transferable because all of my academic career for 20 years, I had worked in contexts of uncertainty, of war and conflict, of migration, and I really was quite worried. And then I realized that there are low resource settings, very deeply low resource settings in the United States. And so I'm also starting to change my language around that there are low resource settings all around the world. And we tend to think about low resource settings in what's called low and middle income country, as if they're different from low income settings in the United States. But rural areas in the United States are like humanitarian settings. I mean, it's almost shocking to say that, right? But I think that's part of changing the narrative around them and us, and where places need help and where places don't need help. And in rural areas, we have exactly the same issues around mental health resources. There are very few mental health resources, and there is a need there as there is everywhere else. So again, thinking about this from a broader perspective of the global impacts on health. So community mental health workers, as you all know, are non-specialized community members who have similar experiences as backgrounds as those that they're providing services for, and who are trained, in this case, to provide specifically mental health services. But we do need more research to understand what is it that community mental health workers can do to support mental distress, particularly in situations that are humanitarian or low-resourced. Which specific intervention are we using? We're using an intervention called Problem Management Plus. It's a World Health Organization developed and implemented and evaluated intervention. It is evidence-based. And Problem Management Plus uses community mental health workers in these it used to be only in humanitarian settings, and COVID sort of opened up the opportunity for PM Plus. So now it's being rolled out in many places around the United States as well. And it's specifically around common mental disorders like anxiety or mild depression, and for mental distress and other problems as a result of daily living circumstances like stress or unemployment or interpersonal conflict. So you can access PM Plus. I can share these slides. It's at that link. It is in multiple languages. And all those languages are accessible. You need to be trained by somebody that's trained to do PM Plus. So it's not that anybody can do it. So there's a very serious training component to become a facilitator or community mental health worker for PM Plus. But it's basically a 5-session psychosocial intervention that was developed by the World Health Organization. And it was originally designed for adult populations affected by humanitarian crises. Now it's adult populations that are affected by any difficult circumstance. There is also a youth and young adult version of PM Plus. It used to be one-on-one. There's now a group format. There is an online format. So a lot of things have expanded from 2013, where PM Plus first came. In individual format, it is 5 sessions of 90 minutes each that the facilitator or the community mental health worker does with the recipient. So again, this idea of a positive mental health strength-based perspective, this is the WHO definition of mental health, a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively. One could argue about productively and the meaning of productive and where it comes from in a capitalistic world, but I'll leave that aside, and is able to make a contribution to his or her community. From the positive mental health or positive youth development perspective, there's a lot of literature that suggests that there are 7 key protective factors that are critical to well-being. And those are positive emotions, hope, positive relationships, finding meaning, accomplishments, autonomy, and engagement. So those are the mechanisms that we're looking at in our study to see how our intervention affects those mechanisms and ultimately affects mental health. And each of those mechanisms has been related separately to indicators of well-being, but also there's a dynamic interaction and synergistic relationship of them to well-being. And so this understanding of what protective factors are potential mechanisms for intervention-related change is also part of the work that we're doing. All right, so our specific aims are to assess the effectiveness of being a young adult community mental health worker on their well-being, coping, and stress levels as compared to equivalent comparison groups of Syrian refugee youth. Our comparison groups are an active comparator of young adults that are doing tutoring in their community, which is also a big need, and a control group that is only providing data. Our second aim is to identify the mechanisms that are associated with changes in well-being, coping, and stress, and we're looking at those 7 potential mechanisms. We are implementing a randomized control design with 3 gender equivalent conditions, which I've explained. And our data collection tools are surveys and then hair cortisol as a biomarker of stress. And our third aim is sort of the implementation science aim, which is the feasibility, acceptability, and fidelity of Syrian refugee young adults as community mental health workers, implementing PM Plus with 400 clients through collection of data from coalition members, clients who receive PM Plus, and the community mental health workers themselves. All right, so this is our figure. You see the 3 groups on the left. So how is intervention working for whom? You see the mechanisms in the middle, and then you see the outcomes that we are measuring on the right. So I want to talk a little bit about history and the importance of history. So yes, there are Syrian refugees in Lebanon now, but there is a long history of interaction between Lebanon and Syria. And in fact, if you go back long enough, Lebanon was part of Greater Syria. And this whole, as you know, this whole region was broken up after World War I by the French and the British. So there's a long history, and we often, I think, come to research ignoring history to the detriment, I think, of all of our work. So just to put a little bit of this in perspective, Lebanon had Syrians in Lebanon way before the Syrian refugee crisis. They were migrant workers that used to come and go between Lebanon and Syria all the time, doing work mostly in agriculture. And they were at that point called migrant workers. There were interactions and policies related to them. And within like a day, these same people went from being called migrant workers to being called refugees. Now, I mean, just again, like think about that shift in terminology, what it means for a person and their dignity, but also what it means just in general in the interaction between people and how people approach you, depending on what you're labeled by somebody else. There also is a lot of geopolitics between Lebanon and Syria. You all probably know that Syria also came in and sort of was occupying Lebanon for a while right after the civil war at the request of the Lebanese government and stayed for a long time. There was a big revolution that got Syria out. So there has been positive and negative interactions between Syria and Lebanon for a very long time. But that all creates an environment that's quite risky for Syrians that are here now, because like half the Lebanese population thinks that wants to interact with Syrians and half of them doesn't want to interact with them at all. And there's no way to know, that a person that steps up to you is either a friend or not a friend. And so that's just the general context. We'll get to the context of Lebanon itself, but just to understand the history is really important to understand the situation of Syrians who are now called refugees in Lebanon at this particular time. I also wanted to just step back and talk about the history of this particular grant that we got, because I think that's all important. And I think we often don't talk about all these issues that really all of us face when we're submitting grants and eventually hopefully get grants. So we first submitted this grant in February 2020. And in October of that year, we were told that we wouldn't be funded. About, 9 months later, in July 2021, we had no contact with NIH since October 2020. All of a sudden, we were told that they wanted to fund this project. So we were really excited about that, but it was complicated because a lot had happened in Lebanon since February 2020 when we had first submitted this grant. So very condensed description of the context In February 2020, there was quite a bit of hope in Lebanon, despite, you know, a difficult circumstance economically and in many other ways. But there had been a citizen revolt in 2019. There was a lot of hope that change was coming in the country. But there was this looming economic crisis. There was a crackdown on demonstrators that was getting stronger. COVID arrived. And then on August 4th, 2020, there was an explosion at the port that really changed the country of Lebanon in ways that are really deep and painful. It was the biggest non-nuclear explosion in the history of the world. And it really destroyed much of the port area of Beirut and resulted in many deaths and many more displaced. With all that, nobody has been, there's no justice related to that or many other things in Lebanon. The Lebanese lira plummeted from 1,500 to the dollar in February 2020 to 90,000 Lebanese liras to the dollar today. So you can imagine what that's doing. And according to the most recent UN statistics, 78% of the people in Lebanon now live in poverty. There's electricity comes and goes, gas is sometimes available, sometimes not, medication you don't know if you can get, and all the staples are in short supply. So, all of a sudden here we get this grant, and now we're even debating the ethics of working only with Syrian refugees. I mean, can we even justify that in the context of Lebanon when it was? So we had a long discussion about that, of course, and part of the issue is we're unlikely to be able to change specific aims of NIH very quickly. And the context is almost even more important to do this work than before. And so we sort of looked at it as a proof of concept, that if we can prove this concept that young adults can meaningfully be engaged to support their communities, and that helps both their communities and young adults, and hopefully this can cascade to a larger group of people eventually. And so we did move forward with that. But just to sort of, again, these are things that will always happen as we're doing the grants that we're doing. And in the meantime, everybody, our NGO decided they couldn't do it anymore because they had been taken up by acute needs of the country. Both of the psychiatrists and the psychologists that had been working with us left Lebanon. There was a huge brain drain. So we had to recreate our team all over again. I also wanted to stop to say, as we got this grant, there was excitement this is a grant that is a partnership between the American University of Beirut, the University of Iowa, and George Mason University. And I meant to put all those logos on and forgot. And we're working with a community-based organization that I'll talk about as well. So our communications offices wanted to talk a lot about this project. So they put up the description, and this was we had been working for 9 months with our community-based organization, really focusing on a partnership, really focusing on changing the narrative, really focusing on trust, trying to build all of that, listening, really centering the community. And the visual that was put up in our communications was this visual. Now, this visual is not, to me, a strength-based visual. It isn't a dignity centering visual. It looks like there's somebody in a tent and they're receiving support from somebody that doesn't at all look like they are. I mean, so it's a very deficit-based. So we stopped right there. We had a huge conversation with communications. We went online and we were trying to find images, and every image that you find about refugees is a negative image. You'll see camps that are flooded, and that is not the image that we are working with at all. And we keep thinking, is there a different word that we can use other than refugee, right? Syrian person, right? But so we now have a folder of pictures that we can share that we and our Community Alliance Committee, which I'll talk about, and our field-based team has agreed are positive images that we want to project. So again, it's the little and the big that we need to pay attention to when we're doing the work in communities. All right, so our research approach is a community engaged approach. You've probably, most of you seen this figure. If you do any community engaged work or have read about community engaged work. And we have done work that's community-based participatory research for a long time in communities that are refugee communities, with Palestinian refugees and now with Syrian refugees, and really feel like that's really the only way to do this work. So we established a community alliance committee. This is what they called themselves. We called them a CAB in the beginning, and they changed their name to Alliance, and I like it. I actually like it. So Community Alliance Committee, 12 members from the Syrian refugee community in the Biqar. We have 6 males and 6 females. We have a teacher, 2 local NGO members, a nurse, a counselor, a young adult who's a university student, a vocational trainer, a physician, a psychologist, a parent from one of the informal tented settlements, actually 2 parents, a dad and a mom from the informal tented settlements. And we first started meeting in July 2022, and then met every other week for an hour and a half to 2 hours up until December. So we had 12 meetings during the planning phase to really get very contextual feedback to all the research processes and tools. This group was incredibly engaged. They provided amazing feedback and suggested important changes to everything that we did, from recruitment processes. They saw they saw the survey, they saw the informational documents that we were giving, the whole process of the survey, of recruitment. I mean, every part of the project they gave comments on, and we went through them each. So what we would usually do is start a meeting sort of saying, introducing the recruitment protocol just as an introduction, then move on to something else, give them a lot of documents, and then the next time come back and really talk through the recruitment. So they had time to think about the recruitment process, think about what we needed to change in it, etc. We are using this sort of conceptual framework in our CBPR project, or in our community engaged project. So this idea that actually community engagement increases relevance, it increases rigor, and increases reach. And we have conducted interviews with our Community Alliance Committee after the planning phase to try to sort of embed the work in this framework. So we filled out all of these boxes, but I'll just sort of stop on 2 things. One is, as part of relevance, we talked about the research goals and what catchment area we should recruit in. And originally we were thinking about, so interestingly, and back to history, Syrian refugees are all over the country. So they're not only in sort of in camps. And the reason that is because the Lebanese government in 1948 basically built 12 camps for the Palestinian refugees. They remain in those camps 70-some years later. And so that experience sort of made the Lebanese government want a different approach. I'm not going to go into the pros and cons of why their choices, but they decided to just not have official camps. Now there are what they're calling informal tented settlements that the UN, it's the UN tents. Some people are staying there, but a lot of Syrians are just, in the Lebanese communities, basically. So we had originally thought to focus on the informal tented settlements, and the Community Alliance Committee, the CAC, said, really, you need to go, there's a need everywhere, so don't just focus on these. So that was like one thing that they made us really rethink our catchment area. The other is there was a huge discussion around hair cortisol measures. This community is a very conservative community, and there were huge concerns about, especially for females, about taking hair, and then what was happening with it, who was going to be seeing it, touching it, etc. All that really big concerns. And so we talked that through with the Community Alliance Committee, and they gave us some really good guidance, including developing a short video that explained the whole process in sort of lay terms that any of the young adults could look at, or anybody in the community to see what the process was. And of course, that anyway, this is all voluntary, like they can be part of the work and not ever give us hair cortisol. So those are just 2 things I'll stop at, but they really helped us in all these things that are on this particular graph. So just some quotes from the Community Alliance Committee and the interviews that we did with them. It's not often that you find that these kinds of studies that are being implemented on the ground to see the community and take their opinion on the research project. These are translated from Arabic. Of course, we did the interviews in Arabic. It was the first experience for me in such a committee, for me to be getting to know how things in research happen and how research is applied in the ground. When I give my opinion, everybody would listen. Everybody would stop and listen. My opinions were taken into consideration. We are listening to everybody, regardless of their experience, regardless of their influence, regardless of their age. So this was about their role to adapt the program to what suited in the context that we live in our community. PM+, it's a study that's being conducted in European and Western societies. We want the study to apply to Syrian refugee communities or the Lebanese community or the place where we are. Meetings were very organized and there was work done before the meeting. The papers were printed beforehand. The surveys we were reading were printed beforehand. This sped up the process. For me, the term mental health or psychological support had a stereotype that was different with people who have mental problems or mental illnesses. You understand them more. I understood now that the term mental illness, and I understood the term mental health in a bigger way, in a practical way. And then sort of, this is my favorite. I think they, the committee, were a guide or compass for the ones leading the study in the community. So just a little bit about their interaction. Just to also say that IRB is really just one level of approval. There's a lot of other approvals that are needed and you should ask about if you're doing work in global settings. So of course we were doing a clinical trial, so we needed to get a clinical trial number from NIH. We had to get IRB approval before we even went to the CAC, but then after the Community Alliance Committee changed everything, we had to go back to the IRB. That took a long time. It's the IRB of record is the American University of Beirut's IRB, because this is where all the work is happening. And again, there was so much brain drain from the university that there was very few people in to do the IRB review. So that took longer than we expected, not by any fault of anybody. There was so much commitment, but just too much pressure on them. We also had to get approval by the Lebanese government's clinical trial branch. So we also have a number here, and approval by the Lebanese Ministry of Public Health Mental Health Program. And I'm really happy that Lebanon has now put these requirements into practice. I would say even if there isn't that in a country, trying to get some local body. I mean, before we had this, we used to go through one of the university IRBs. Or when I was here, we would ask somebody to go through our IRB as well, because there are, there's contextual issues that are just not comprehensible or understandable by somebody that's living in such a different context. All right, so I'm going to talk a little bit about recruitment. I'm clearly not going to get through all my slides, so I'll go through them fast because there's some towards the end that I want to talk about. But this was basically our recruitment process. For the young adults, we also have a recruitment process, of course, for the recipients of PM+. The young adult submits an application that is an interest form. There's a first screening. And then if they're screened, they undergo, this is all PM+ required processes, okay? So we're following a protocol that's already basically been set by Problem Management Plus and WHO. They undergo a clinical assessment, and the numbers here are about what the literature said. So the assumption was that we would find about 20% that had acute mental health distress. Those are referred, and we had an NGO, an international NGO, an INGO, that had committed to providing services for anybody that was referred from the young adults or the adult recipients. And then once for those that are not referred, they are then randomized into these three groups. They're trained on PM+ or tutoring if they're in the intervention groups. For PM+, they undergo supervised practice. So there's a psychologist, a PM+ trained psychologist that follows them with two of the recipients until they feel comfortable doing it. Their competency is assessed. So there's a particular PM+ competency assessment. And again, that 15% for what came from the literature, that there's about 10 to 15% that are judged to be not competent. And that's how you sort of get, so we were working backwards. If we wanted 20-20-20, it's really powered at 19-19 in the two intervention groups. We sort of moved back, if we lose 4% here and lose 20% here. And so we felt like we had to recruit 115 young adults to be able to get to the numbers that we wanted in the three groups. And so here are some, just again, I'm explaining the process because these processes, you can plan a beautiful plan and it will never work like you plan, just to say that. So we actually got 1,226 young adults that completed the online interest form. The criteria were being a Syrian refugee, 18 to 24 years old, having graduated from high school, and living in one of the 4 catchment areas that are served by the NGO that we're working with. And they had to have been involved in NGO or service in their community. It doesn't have, it didn't have to be major, but they had done something in their community and expressed a motivation to serve their community. So those were sort of the criteria. And so of those 1226, there were a lot that actually didn't meet these criteria, even though those were criteria on the front page, they still filled in an interest form. So we ended up with 146 in the first phase and 142 in the second phase, adults that met all the criteria. You'll see that we wanted, as I said, gender equivalent groups. We got many, many, many more females than males. We actually then stopped recruiting females so that we could get more males. Now, in hindsight, this is not necessarily surprising because community mental health work and tutoring is socialized to be a more female type task. So, we should have thought about that earlier. We were just, well, no, we want, equal numbers. And we had talked to a bunch of we have a group, we have 2 psychiatrists that are PM Plus psychiatrists, have been there since the beginning of PM Plus, but we also talked with people that implement PM Plus and saw that they had the same experiences. I'm not going to go through all this because it is quite detailed, and I thought I'd be able to get through it, but I think the story is taking longer than I wanted, and the story is important. We, asked them questions, they answered it. We also had, rating scales for how we answered these questions. So we eventually shortlisted 151 females and 79 males. We held informational sessions where we went through every single part of the process. And of those that attended the information sessions, so 147 out of 230 attended the information session. So again, this shows you how you lose, like at every step of the process, you lose people for various reasons, not all reasons that we know. There was 127 eligible young adults after the information sessions. We had asked for documentation of their degree and documentation of their age. And if they didn't have it, unfortunately, we couldn't keep them in. So we had 117 that were consented and went through the clinical assessment. Contrary to what we found in the literature, only 2 of those 117 needed referral. So we still had 115 when we thought we would have 92. So we ended up randomly selecting 92 out of 115 and breaking them up into the groups. The reason we couldn't keep all the 115 is that we're actually compensating for the work of the community mental health workers and the tutors and for the surveys that the control group is giving us. And so there just wasn't enough money in the budget to be able to keep all 115. I'm going to skip these. This is just sort of the process that we went through. I just want to stop because, again, these things, there's things that happen all the time. We started the training of community mental health workers and tutors in April 26. And on May 1, we had to stop because the Lebanese government decided to do a mass raid to deport Syrian refugees that didn't have legal papers. So they went into their homes. The NGO shut down completely, and for a month, nobody left their homes. So that was horrible for everybody. We kept contact with them to make sure that they knew, that we were supporting them, to show solidarity, to, whatever we could do to support them when we weren't interacting with them face to face. And then what we did is decided to refield a really short survey after that. We had embedded into the original pre-assessment survey a measure of sort of stigma and discrimination because we wanted to keep we wanted to be able to actually show that no matter what, so what we're doing is good work, but in principle, we shouldn't have refugees to begin with. And so we wanted to be able to somehow continue to measure an aspect of stigma and discrimination against refugees in a particular context. So I'm just showing you sort of data that we got from the pre and post. And interestingly enough, we had gone into it thinking, we used the brief perceived ethnic discrimination scale, the community version, and we had thought that stigma and discrimination would get higher because of the raid. But because they were in their homes, they were experiencing less direct stigma and discrimination. So we in fact found, less discrimination, but still not well-being was affected from their being at home. That's not a surprise. And we did find a link between stigma and well-being. So where stigma got worse, well-being got worse as well. So again, just, how do we think creatively on our feet and pivot when we need to be able to try to capture data that can help make arguments that are much bigger than any specific research project that we're doing. The next step, of course, of all this is a rollout to adult recipients in our community. So for adult recipients, they also put in an interest form. And if they meet the criteria, which are, again, Syrian refugee living in one of the areas that we are serving, they also have to take these two assessments, the General Health Questionnaire 12 and the WHO Disability Assessment Schedule. And the reason for that is because PM+ is a low-intensity psychosocial intervention. And young adults who are trained in PM+, or anybody that's trained in PM+, is also trained to know when they need to refer. And so this is sort of the 3x2 of when a person is included. They have to have a GHQ between 15 and 20, but not over 20. And they have to have a WHO disability assessment schedule of greater than 17. And all the rest are either excluded because there's a perception of, or a measurement of too little distress, or they need to be referred because they're not a low psychosocial intervention. So you'll remember that only 2 of our young adults needed referral. 80% of our community members have needed referral. So now we are in conversation with, again, our psychiatrists from PM+, who are actually finding this in more than one community. And our psychologist came back to us way before, as we were starting to recruit adults, saying she was really frustrated because she felt like a lot of those that she was talking to refer were really good candidates for PM+. So this idea is that there's so much stress in this community that you could be, scoring high on an instrument, but in fact not be, in the category of needing psychiatric assistance, and could be served by a low-intensity psychosocial support intervention. So we're now in the process of changing the protocol to basically, as long as they don't have acute distress, suicidality, or psychosis, they are included, basically, and can go through PM+. And at any time, the young adults are continuously connected to a psychologist, and at any time she can support, if they need referral, she can support them in referring clients. So again, it's this experience that you try to implement a particular protocol, but there are situations on the ground that that make it necessary to rethink things. When we were doing our intervention in the Palestinian refugee camp with youth and young adults, I remember looking at a lot of the psychiatric instruments, or these epidemiological mental health instruments, thinking, if I took this instrument, I would say yes to every single one of these questions. So there's a context that makes it's not good that this is the case, but there's a context in which one can be very functional in very difficult situations. So our work continues. Again, this is a story of what's happening, and it continues to be a story. I do want to stop for a minute on the word resilience. We use the word resilience a lot. I don't like it at all. And this quote from Saad Amrad, I think, really encapsulates why I have a really negative reaction to resilience in my own life. Throughout, the war in Lebanon, it was always about Lebanese people being resilient, or Palestinians being resilient, or Syrians being resilient. This quote says, "Resilience celebrates survival at the expense of justice. It's the rhetorical and symbolic symptom of the normalization of injustice." And I really like it. So we are not using the word resilience at all in any of the work that we do. And I would encourage you to rethink the word resilience. So our vision is that young adults in contexts of uncertainty are meaningfully and with dignity working to support their communities and that enhances their own well-being and that of their communities. This is our research team. A big chunk of the research team is based in Lebanon. Our mental health team is all based in Lebanon. And we're working with Multi-Aid Programs. It's a Syrian NGO. And we worked really hard before, like we talked to a lot of NGOs before we co-selected. They selected us and we selected them. And you'll see at the top of there, is dignity. And a lot of what got us to work together is that we came from the same frame of reference of changing the narrative around refugees. So the big picture core components of the project that we think we're adding to the literature is focusing on youth as change agents, identifying the impact and the mechanism of being a community mental health worker, including a really thorough implementation evaluation and community engaged research in humanitarian settings. And I'll stop there. Open for questions. And I'm sorry I went probably more than I wanted to.
Thank you so much, Rima. That was really powerful and just so interesting. And I'm sure we could have many hours of conversations of discussion. You gave us a lot to think about. Attendees, I think the question and answer modality should be available to you if you want. So please feel free to use that to pose a question. While others kind of think about and digest a little bit, I just have a clarification question, and I'm sure you said it and it just didn't land. So are the young adults delivering intervention content to other young adults?
No, so I didn't say that. It's to all adults, anybody 18 plus, not anybody that's under 18, but anybody that's 18 plus. And that's part of the sort of feasibility question that we're asking. Will somebody that's 50 accept to be supported in this way by a person that's 18 or 19?
That was my question, is like just thinking about generational differences and kind of intergenerational work. What are like middle and older adults' reactions to receiving kind of peer-led mental health work from a younger
person? Yeah. And because it's been so hard to recruit, I mean, that'll be interesting to see if we can actually recruit the 400 we need, given the numbers that we're seeing. I think it'll be more possible once we change the protocol. But so far we have 3 community members that have been linked to young adult mental health workers. I don't know their age, so I can't answer that question. But so far it's been going well. So hopefully people will accept that.
Interesting. And how are you navigating language? So are the young adults, are the trainings in?
Everything's in Arabic. Mm-hmm.
Okay.
Everything's in Arabic. Yeah.
Yeah, I mean, one thing that, we've noticed in our refugee, immigrant, migrant communities in Clarkston is that, when we've done like surveys, community-based surveys, the young people, the children are, says, I think, is a double-edged sword. They're often translating for their parents. Yeah. So they're more likely to be kind of fully bilingual just because like they're in school, they're being taught in English. Yes. And so I just always think about I don't know the right word, the responsibility of that for a young person.
It is. And it changes the dynamics in a family as well.
Yes. So. I mean, we've had like young kids trying to help, like 5- and 6-year-olds trying to help with translating into English and back into their native languages. And I just think about the maybe privilege of that, and also
it's a both and
of that.
Yes, it's a both and right. Yeah, absolutely.
Any other questions for Rima today? I don't know if I'm trying to make sure that the Q&A is working. It looks like it is.
and people can feel free to reach out to me, you know, afterwards as well.
Absolutely. Yeah.
Happy to chat.
I mean, I have one
I
more
think
question.
one of the things, okay.
Well, you know, I was just thinking about what you said, like in your first or second slide, when you were talking about, you know, that we just don't see young adults represented in kind of media depictions in like refugee crises. Like, where are these young adults? And I just wonder if you have any thoughts about that, because you're totally right. After you pointed it out, I thought to myself, you're right. I don't see images of young adults very often. You see parents and you see babies.
Right.
So why do you think that is?
I think because they're generally felt to be like healthy, you know, like they're healthy, they're less likely to be, you know, they can take care of themselves to some extent. It's the only thing that I can think about. And they're sort of stuck in between childhood and adulthood. And so, but again, if they don't have anything to do as anybody else would, I mean, there's lots of things to do that aren't great things to do as well. And there's, you know, and the environment is ripe for that. So that's just an extra. Plus, I kept thinking, I mean, during the, you know, one of the wars in Lebanon, when there was a huge mass movement from the south to Beirut, and you know, people were living in very cramped circumstances, I kept thinking, even if these young people would just take care of the children so that the mom could get a break for 10 minutes or 15, like, you know, it doesn't have to be a really complicated intervention to support the community. I just think there's so much potential, and they have so much energy and they have so much hope. You know, they're not jaded like we sometimes, you know, they're like, no, we can still change the world. I'm like, yes.
I know. I mean, they're an incredible resource.
Yes, they really are. It's so powerful to work with young people.
So you do have a couple of questions, Rima, in the Q&A section. We have about 1 minute. So Michael Erickson is asking about, you seem to have lots of young community mental health workers, but few service recipients. How do you keep the mental health workers engaged when there are currently few clients?
Right. So that's part of the process. Thanks, Michael, for that question. That's part of what we're trying to figure out. And because we just started the rollout, I think we're okay. We also, I will say, I think we have a very, I don't know if biased is, but maybe it is biased group of young people. They're of course, all have their high school degrees, and most of them are in university. So they also have other things that are keeping them busy while they're, you know, waiting to be connected to clients or recipients. And yes, Yasmin, I do think that that may be it as well, right? Like, what brings in more money? Young children seem to do that. Yes, it's a good response.
Yeah. All right, well, let's end there since we're at the top of the hour. And, you know, Rima, thank you again for this fascinating and I think really inspiring work that you're doing. And I hope you'll come back and share your results with us in another year.
A couple years.
There'll be more challenges that you'll be able to share with us that we can learn from. So
I mean, it's interesting because there was also there was the big earthquake. Like, at every point, there's like, okay, how much do you gather data? Because it's going to be continuous, right? At some point, we just decided we're not going to, every time something happens, gather data, because it's really continuous. Yeah.
And that's exactly, you know, you're learning lessons as you go, and those lessons can be shared and we can all learn from them. So we're looking forward to learning more from you.
Appreciate the
invitation. Thank you for being with us tonight, your time.
Thank you.
And thank you all for joining today. And we look forward to you joining in the future at the next webinar, which is going to be next month, November the 2nd. And we're having Dr. Catherine Yoon talk about a linguistically and culturally specific childhood vaccine safety education intervention for Ukrainian, Afghan, and Congolese community members. So a really diverse group there. So we hope you'll join us for that. Thank you all so much. Have a great rest of your week and weekend. Bye-bye.